El día de hoy en esta sesión mensual de SOMERA. Es un privilegio acompañarlos y ser parte de este espacio académico que busca generar diálogo, intercambio de ideas y crecimiento colectivo. Esta noche contaremos con la destacada participación del Dr. Drew Muganaki, reconocido internacionalmente en el manejo del cáncer de pulmón. La sesión se desarrollará con una exposición principal de nuestro ponente, seguida de un espacio abierto para preguntas y respuestas. Les recuerdo que contamos con servicio de traducción simultánea, por lo que pueden hacer sus preguntas en el idioma en el que se sientan más cómodos. Les invito a aprovechar esta oportunidad para interactuar con nuestro invitado y enriquecer la discusión. Procederé a continuar como programado. Good evening, everyone, and welcome to this very special edition of our SOMERA webinar series. We are truly excited and honored to host this session live from Mexico, and we know we have colleagues joining us tonight from across the country and beyond. Tonight's session is especially meaningful as we welcome a guest who is not only a world-class researcher and clinician, but also someone who has inspired many of us with his thoughtful, bold, and inclusive vision for the future of radiation oncology. Please join me in welcoming Dr. Drew Moganaki, Chief of Thoracic Oncology at UCLA and Director of the Veterans Affairs National Lung Cancer Working Group. Dr. Moganaki is known globally for his work in stereotactic body radiation therapy and for leading several phase 2 and 3 clinical trials aimed at improving outcomes in patients with early stage and metastatic lung cancer. He has published extensively in The Lancet Oncology, JAMA Oncology, and is a leading voice in health equity, access to care, and the integration of radiation and immunotherapy. Dr. Moganaki, welcome to our forum in Mexico. You have many admirers in our community who have followed your work over the years. It's a privilege to have you here. The title of tonight's lecture is Radiotherapy for the Management of Lung Cancer. So without further delay, Dr. Moganaki, the audience is yours.
Antonio and SOMERA organizers, thank you so much for the invitation. It means a lot for me to speak to radiation oncologists in other countries, as I think you can understand. It is an honor for me to be invited back again, and my hope is at the end of this lecture, you will learn at least a few new things that you don't know already. So for the outline, in 40 minutes, I think we can do this. We will cover 6 topics. First, we will discuss SBRT for stage 1, both operable and inoperable. Then I want to be sure everyone knows the latest research on post-operative radiotherapy for lung cancer. Number 3, we give chemo-RT all the time, but there are new safety issues I hope everyone is aware of in the current era in 2025. Number 4, we will discuss this topic, very controversial, about radiation therapy for stage 4 lung cancer and safety issues. Number 5, I will touch briefly about liquid biopsies. And then number 6, my favorite part, we'll save for the last, how to be the jefe in the multidisciplinary team as a radiation oncologist. So number 1, we will discuss this amazing treatment pioneered by the Swedish team in Karolinska Institute, later Japan and the Netherlands, and then eventually in the US with the Timmerman phase 1 trial, phase 2 trial, and now the phase 3 trial in the US. So I think it's important to see where we are today with the utilization of SBRT and the patient satisfaction. This is the latest data. It is currently under review in a major American journal. I hope it is published. I am the senior author of this with this amazing medical student who is now a general surgery resident at Harvard's Massachusetts General Hospital, Sarah Sakowitz, brilliant physician scientist, has 70 publications before finishing medical school. And she very graciously agreed to lead this study where we had the very early access to the most recent data set from the NCDB. Previously, the NCDB was only updated to 2016. So I was very curious what happened between 2016 and 2020. More than 700,000 patients with stage 1 lung cancer at many hospitals in the US report to the NCDB. And in the orange, you can see the steady ongoing decline of surgery. And the main reason is because of the gray, which is SBRT increasing in the proportion of patients either being referred for SBRT or choosing SBRT. In the blue, we see that even in the US, there are still many patients, many places, and many patients who don't have access to SBRT, and so they are treated with, I don't know, maybe 15 fractions or 30 fractions. And then in the red, you will see the percentage of patients who get no treatment at all. And I think that as SBRT has become more familiar, more and more patients who are too frail for surgery at least are getting something as opposed to nothing. And I think it's important to see when you add the gray and the blue together, those are the radiation patients. And unfortunately, more than a quarter of patients in the US still do not have access to SBRT. But ultimately, this ongoing decline of surgery for me is a little bit concerning. I was hoping it would slow down, and we don't know where it is today in 2025. Next, I want to show some data from UCLA where we are now better understanding what do people with lung cancer think about surgery and SBRT. So in a study done by Shaverdian, who is now at the Memorial Sloan Kettering and the chief of thoracic radiation oncology there, when he was a resident at UCLA, did this study where they called 41 patients who had been treated with surgery and then for a second lung cancer, because we know lots of time when patients get one lung cancer, they will get another lung cancer. They had all had surgery, and almost 90% of them said, sure, I will respond to your survey. And they asked them the following questions. Did you ever know about SBRT? And as we know, more than half of them didn't even know it was an option before they had surgery. When they compared their lived experience with surgery and with SBRT, there's no surprise. All of them said SBRT was easier to recover and side effects. All of them said it was less stressful and anxiety provoking. All of them said less strain on their caregiver and their family. Almost all of them said it was more convenient. I think some of them don't like coming for 5 trips in the simulation. And 80% of them were more satisfied. And we have to remember this because there are still some patients who get very anxious that they didn't have surgery, and that might be the reason. And unfortunately, for the surgical experience, because I think surgery is very important in many situations, 0% of them were more satisfied with surgery. And then here's the final statistic. If they knew about the 2 treatments, this is what they would have chosen. 90% would have chosen SBRT. And to me, this study, even though it was 10 years ago, gives us a glimpse into the future. Well, what does the future look like? What is the latest state-of-the-art data of SBRT in surgery? And I recommend everyone, you can just absolutely ignore all of the retrospective data. It is confounded. Patients who got SBRT, for some reason or another, were not eligible for surgery. Surgery is the standard of care. To deliver non-standard of care is unethical, and it has possible legal lawsuit implications. So the only people getting SBRT in retrospective data have something, there's a major issue with those patients. But there are 4 prospective comparisons where they tried their best, first of all, to try to randomize the patients. 58 patients. Now, this study is almost 20 years old in the first enrolled patient, 2008. With a median follow-up of 3.4 years, 58 patients randomized in the STARS randomized trial in the US and the Roselle randomized trial in the Netherlands. This is not a typological error. The SBRT arm was the better overall survival. Now, there's been lots of arguments about, well, the surgery arm underperformed. I said, you know what? You can ignore the surgery arm. Just look at the blue line. Those are incredible statistics, and forget about the comparison. When you take a patient who is actually operable eligible for randomization to either treatment. This is the outcomes you can achieve.
Pues para estar a las 8 en televisión.
At MD Anderson, I think a microphone is still on here. At MD Anderson, after the results, the STAR study was published in 2015, they did a new study, brand new, 80 patients in the surgery department who were eligible for a VATS lobectomy underwent SBRT instead. In blue, you see their overall survival. So these were, again, once again, operable patients. They did a propensity matching to say, well, at MD Anderson, we have the SBRT, and at MD Anderson, we have the best surgery. How did the patient at MD Anderson who had the best surgery do? Did they do better? Well, they found the best surgery by the following. You can see here, and I believe that here the colors are miscoded, unfortunately. But the blue line, actually, in the legend, you see it is VATS, so minimally invasive, lobectomy, not sublobar, a lobectomy, plus the mediastinal lymph node dissection. 10% of the mediastinal lymph node dissection patients were found to have micrometastatic disease, and all of them received the adjuvant platinum doublet chemotherapy, which is what we think the benefit of surgery is earlier detection of some metastatic disease. And even with surgery plus chemotherapy in 10%, the survival was no better than upfront surgery SBRT with surveillance and salvage at the time of relapse. There is a third study from the Netherlands that is less commonly discussed. This was only published last year. This is several dozen hospitals throughout the Netherlands were registering patients, whether they received surgery or SBRT, and then they went backwards and they did the best that they could to match them in prospective follow-up nature. Now, unfortunately, here in this situation, the SBRT patients were probably sicker because they weren't randomized. But even then, when they matched them by tumor, by comorbidity, no measurable difference. We really are in an unprecedented time where we no longer know why we do surgery. And then finally, also published in the last couple of years, the world's largest lung screening program, ILCAP, has now started tracking their patients with IL-CART. The T in IL-CART stands for treatment. And over this time period, they have a follow-up period of 5 years, 1,000 patients diagnosed with screen-detected lung cancer underwent surgery, and you see their outcomes. And then SBRT is slowly becoming more and more utilized. And again, there is no difference. For them, they reported lung cancer-specific survival because in a non-randomized cohort, there's more comorbidities and more competing risks for death. So again, for small tumors, clinical and zero, we are in an unprecedented time and really need to justify why we are doing surgery. Many of you are already aware of this study that we're leading in the VA, and here is the schema. We are randomizing 670 operable patients who are seen by the pulmonologist, the surgeon, and the radiation oncologist, who are all working very well together in the VA. We just randomized 10 more patients last month. We are at almost 500 randomized, and ultimately you can see we are looking for overall survival. The surgery must be lobectomy or segmentectomy. Wedge resection is not allowed. And of course, all of these patients must have a lymph node dissection or at least sampling at the time of resection with at least 3 mediastinal lymph node stations so that they can get the adjuvant therapy, because that's the benefit of surgery is earlier adjuvant therapy. So that's the real question in this study. Local control, we know, is spectacular with SBRT. The real question is, how often will you find metastatic disease, and will that earlier systemic therapy make a difference for survival? Now, before I move to the next section, I want to remind everyone about ultracentral lung tumors, where SBRT, my opinion, is still experimental. This is the very famous HILAS trial published in 2021. If you look at the appendix, I'm very grateful for the study authors to publish this. All of these patients died from SBRT complication. They gave the dose not in 5, but 8 fractions. And even that, it was just too much. We've written editorials about this, talking about, well, maybe, they could have used better image guidance, and maybe they shouldn't have put 1 centimeter. Some places in Scandinavia actually put 1.5 centimeters PTV margin. We can talk about that all we want, but ultimately, in this latest editorial that we wrote with a colleague you may know, Dr. Huertas and Dr. Siva, we said, why even bother? Just give 15 fractions. It's a very good treatment. The outcomes are excellent, and you just do not see major complications. So my practice, anything that's ultracentral, I give 4 gray times 15, and I use the best image guidance that I can, and I only put a 5 millimeter PTV margin. Outcomes have been fantastic. Just because I'm moving from SBRT to IMRT does not mean I start adding bigger margins. Just like SBRT, I only add 5 millimeter margins to hyperfractionation. The patients do fantastic. No one has died, knock on wood, under my watch. So that was the first section. The second section is this topic of postoperative radiotherapy, where the surgeon takes the patient to the operating room. We all think it's the right thing to do, and then, oops, there's cancer in the lymph nodes. Especially today. Today, if you know this clinical N2 disease, if the patient's going down surgery, we give preoperative chemotherapy and better yet, chemoimmunotherapy. But sometimes you don't know, so you go to the operating room and afterwards the patient is presented with oops, N2 disease. We now have definitive data on what to do after half a century of debates about whether to give radiation to the lymph nodes. It was always my opinion that radiation doesn't help these patients. If the cancer has spread to the lymph nodes, it has spread elsewhere. The problem isn't just the lymph nodes. The problem is the whole body. And as the drugs has gotten better, I think that radiation to the mediastinum is too little, too late. Well, we now have phase 3 randomized clinical trial data that confirms that that was the correct way to think about it. And all of this time, since my residency in the 2000s, I was in the minority. There was so much excitement that radiation was helping these people, and I was always uncomfortable just delivering 50 gray to the mediastinum where we would cause esophagitis. This study, run in Europe, was designed to show a 3-year disease-free survival benefit from 30 to 40%. And it's very important to remember the study design. Very mild ambition, or maybe too big of an ambition, but ultimately look at the results. The control arm of just no port actually did better at 44%, and then the benefit was only 3%. Not any better. There is your 95% confidence interval. And people will argue, well, Dr. Moganaki, maybe if it was only single lymph node station, well, there's your difference in disease-free survival between port and no port. Well, Dr. Moganaki, for multi-station, what about them? No, they both do very poorly. What about a patient has extracapsular extension? I have to clean up the mediastinum with radiation. They both do poorly. Same thing with clean margins, R1 resection or R unknown. And then maybe if the patient didn't get chemotherapy, radiation would help them. Same problem. And then if you looked at the overall survival, it was actually upside down. The patients were more likely to live if you didn't irradiate the mediastinum and the esophagus. So I think that port is basically dead until we come out with a better risk stratification of who to treat. So when the patient's presented to MDT after surgery, I don't even talk to them because I don't want to confuse them. They just see the medical oncologist and figure out what postoperative chemo or immunotherapy they're going to get. Topic number 3. So chemo RT, I think you cannot really be a radiation oncologist unless you know how to design and deliver this treatment. But the game is different today because of new ways we treat stage 3 lung cancer, non-small cell, and also we now have a new way of treating limited stage small cell lung cancer. Today, the standard of care for stage 3 lung cancer is chemo RT, recovering and restaging, and then 1 year of monthly durvalumab. That's if it's stage 3 non-small cell. And if it's limited stage, this is very easy for the residents to remember. It's the same regimen, except you give 2 years of durvalumab. And the benefits are substantial, which I'll show on the next slide. We now also have a third study. This is the LAURA trial. If you're EGFR positive, so this reminds us now before chemo-RT or during chemo-RT, you must get EGFR testing for stage 3. And because durvalumab does not work for EGFR positive patients, those patients get osimertinib, and the duration actually is until the time of progression. It's important for radiation oncologists to know this so it's not embarrassing. There are many different types of EGFR mutations. So in your notes, do not just say EGFR positive. Write down the type of EGFR mutation, because these two mutations are the only ones that are sensitive to osimertinib, which was the drug that was studied in the LAURA trial, is exon 19 deletion and L858R. These should not be foreign terms. You should know them well and speak it as normal language. It will earn the respect of your medical oncologist, because they too have to look at the type of EGFR mutation. So here is the Pacific trial for stage 3 non-small cell lung cancer. And I just want to emphasize the magnitude of benefit. On the left, overall survival. It's basically 10% if they get the durva. And on the right, I love this curve. When you have an intact disease that you're tracking on images, you don't call it disease-free survival because there's something to see. You're curious if it's progressing or not. And here, when the tumor never progresses, that means there's no more treatment. In my mind, that means cure. So we are literally curing 33% on the right, PFS at 5 years. And if you do not give the durvalumab, you're only curing 20%. And the cure doesn't come from the radiation, it comes from the drug. And it is absolutely crucial that we do not injure the patient during chemo-RT, because then they might not get the drug. If they end up with pneumonitis, the medical oncologist will become concerned, maybe stop the durvalumab. Or if the patient actually gets pneumonitis during and right after radiation, they might not ever get any durva. And then they end up on the red curve. And whose fault is that? It's our fault. We must not cause pneumonitis. For the limited stage small cell lung cancer, Adriatic trial, this is now, at least in the US, a board exam issue. This now shows, again, with durvalumab after chemo-RT, whether BID or QD, again, 10% overall survival benefit. And on the right, I love this curve. This shows how many people we are curing, but only if they get on the, they don't have pneumonitis and get the durvalumab can they be on the orange curve. Otherwise, your patient will be on the blue curve, recovering from pneumonitis. So how do you minimize pneumonitis? And we'll talk about that on the next slide. And then this slide comes from Dr. Suresh Senan from the Netherlands presentation earlier this year of the brain metastasis protection with durvalumab. It's unclear, this topic of omitting PCI, but nonetheless, it just goes to show that this is a good drug and we must not interfere with the delivery of this drug. After these trials, and then of course there is the LAURA trial where they give osimertinib after chemo-RT, we must never design treatments like this again. These treatments cause pneumonitis. The entire prescription is being given to the entire APPA and then the obliques. This is unacceptable, and it can increases the likelihood of the patient being hospitalized, missing appointments, months going by, and not getting the durvalumab. So how do we do better? Well, I have been using IMRT for many, many years. There's lots of papers now, especially after the 0617 study of the prospective data set and other trials showing that IMRT is a better form of treatment. You take the high dose and you only put the high dose on the tumor and you reduce the low dose to the other areas. And we see amazing outcomes, especially when the esophagus is going close through the area and you can carve the dose out of the esophagus where there aren't any lymph nodes involved. And then ultimately have the patient get through treatment and to their systemic therapy more effectively. Now, People often think this is a crazy idea, but some of the leading institutions in the US, including UCLA, when we design our treatments for IMRT, chemo RT, we do not add a CTV anymore. We use the same principles of SBRT. We just add 5 millimeters, maybe sometimes 7, depending on the size of the tumor and setup uncertainties. But 5 to 7 PTV, that's it. 0 CTV. This is a study from Salma Jabor's group, where they retrospectively looked at the different practices there of different margins. So for their patients getting chemo RT, they saw a range when you added up the CTV but PTV margin. So on the left, there were some patients that just got 5 millimeters total. And then on the right, you can see some people, when you added the CTV plus the PTV, you get 8, 10, 12 millimeters to the PTV. You're delivering all that dose to this entire cloud of normal lung tissue and esophagus. And when the patient gets esophagitis, they stop eating, they get malnourished, and that also affects their health as well. So what happened at this institution? Did the patients with the smaller margins have more relapse? Who was the patient who had smaller margin? It turned out whenever the planner found a very tough DVH, bigger volumes, that was when they decreased the margin so they could pass the V20. So therefore, the smaller margin has 2 reasons to have worse failure. First of all, you might be missing the margin. Second, these were the patients with bigger tumors. And look at this. The patients with the smaller margins on the dotted line had less local progression. Basically, there's no difference here. This is just statistical noise. But there was no significant increase in failure if you went with the smaller margins. And as you would expect, when they looked at the side effects, again, bigger tumor, smaller margins, yet still less pneumonitis and less esophagitis, cut by 2/3, from 31% down to 11%. This is a life-saving technique, and I cannot emphasize it anymore. I will never use a CTV again until I convincingly see multiple failures, and I have yet to see a failure. My colleagues at Stanford also dropped the CTV more than 10 years ago, and they just are not seeing marginal failures. And this is where we should be in 2025. Finally, when it comes to safety issues for chemo RT, I want to talk about the patient who actually can't get chemo and what should we do. This is one of also my favorite studies completed by Puneeth Iyengar. This was a Texas study. Most of the patients were at UT Southwestern. I think there were some other hospitals there. But ultimately, almost 100 patients who were so frail, the medical oncologist said, okay, well, good luck. Give RT alone for node-positive disease. Let's see what happens. And, UT Southwestern has all this technology, and they say, well, we have image-guided hypofractionated radiotherapy. We can deliver it safely in 3 weeks. And it's higher BED if you give 60 gray in 3 weeks versus 60 gray in 6 weeks. So what were the results? As you would expect, the local control was very good, over 85, around 85% versus 2 gray per day without chemo. What about distant metastasis? Well, this is great. You control the primary tumor, less distant metastasis. What about survival? Should be equal or better survival, right? This is not a typo. The patient who were treated harder and faster died faster. And when you look at the toxicity table of the study, you don't see grade 3 toxicities or grade 4 or grade 5. What you see is grade 2. Grade 2 toxicities was enough to kill these patients. We have to be extra gentle with the patient who's so frail they cannot get chemotherapy, and unfortunately, a burden to the family because they probably can't drive. They really should come in 6 weeks. Now, are there times where I might try faster? I don't know. Maybe if the tumor is very small and not involving the esophagus, but this is stage 3, when the lymph nodes are involved and the mediastinum is going to be treated. Topic number 4, safety of radiation for stage 4 lung cancer. So people are getting pretty excited, but we have a problem. We really thought that this helps people, and we're not sure exactly who it helps. So the whole premise behind bringing radiation back into this local therapy topic, sometimes even surgery or percutaneous ablation, It's because today we still have very limited options for the patients with metastatic disease. So I start at the letter X because it is it, and near the end of the alphabet. The patient has metastatic disease, they say the medical oncologist, and they get the drug X. And drug X only works for so long, and then they go to drug Y, and then Z, and then there's no more drugs, and then they die. So the principle is, well, if you give local therapy, maybe they stay on drug X longer. They get more mileage out of drug X. And then they go to Y and Z. And maybe if they relapse a second time and a third time, you keep pushing death down the road and people will live longer. And so we had all this enthusiasm about it. And David Palma posted this online just this week, where they have this study called ARREST-2, and they're treating all these metastases. This is their patient. Actually, if you go online, he has a video here. I was unable to download the video. And they had 16 pulmonary Mets. They all got 7 grade times 5. Those are all the constraints. And the question is, because we can, should we, will it help them? Well, you might be aware that about 8 to 10 years ago, there was these phase 2 randomized trial by Iyengar and Gomez that showed a positive signal. But just last year at ASCO, we unfortunately learned that in the phase 2/3 randomized trial of the LU002, they took patients with metastatic disease. They got their standard chemotherapy plus or minus immunotherapy. 90% got immunotherapy. Then they randomized them to continue the drug immunotherapy or give some radiation cleanup just to be safe. And will that increase the time until relapse and progression to the next drug? No measurable difference, so they stopped the trial after just 215 patients. And down below, you can see no signal at all of overall survival benefit. These data have not yet been published because the NRG team is trying to find the subset that did benefit from it, because I think there are many who do, but the same number that do are the same numbers that don't or might get hurt. And right now, it's just not a good policy just to give it because the cancer didn't disappear. If it's stable, we just watch it for now. I think at a time of progression, something. But one thing is, we, again, just like the other story, we can't hurt the patient. If we hurt the patient, they end up with pneumonitis, they end up on steroids. Often they cannot go back on the immunotherapy or the other drug that they were on. If there's a clinical trial, at least in the US or many actually global trials, once you go on steroids, you become disqualified from future trials. We cannot cause pneumonitis anymore because the drugs are getting better and better. And, once we start hurting people, I think, it creates very big problems. Getting near to the end of the presentation, topic number 5, this issue of liquid biopsies. Does it help us or not? Well, there are so many different types now. There is, start from the top left, the ctDNA, circulating tumor cell at the top right. You have exosomes, cell-free DNA, proteins, other things, microRNA, metabolites. And these are all still generally investigational. We're also looking at saliva, nasal swabs, urine, sputum, etc. It is my understanding that at least for early lung cancer detection, the stage 1 tumors just are not shedding. There is a test out there called the GRAIL test. It is only 22% sensitive for stage 1. I think, and I work with a pulmonology research team at UCLA, we think that the most promising to at least identify the early stage 1, is when the tumor is growing and the immune system is doing this dance with the tumor, and there is this immune surveillance and it keeps it at check, and there's a fight. And the tumor secretes the proteins, metalloproteinases, and the immune system fights back, etc. And eventually the tumor beats the immune system and grows. At that time, actually something called proteases are being leaked into the blood, and there are new generation tests that are measuring those proteases. For me right now in 2025, that's what I have the most hope on. When it comes to surveilling the patient who's been treated and should they get more drug therapy, there are good tests, minimum residual disease tests, that can detect whether the cancer is starting to grow again. And usually what they do is they give you about a 6 to 9 month lead on the scan. And the big question right now is, so what if is switching the drug earlier make a difference or not? There still needs to be large studies to confirm that these things help people. So generally right now, we are very reluctant, even at UCLA, where we have the resources to order these tests, we very seldomly use it. Sometimes in our EGFR positive patients, I described the 2 mutations that are sensitive to osimertinib. If a tumor is growing during osimertinib and the patient comes to me and they say, well, let's zap this thing, They will get a liquid biopsy to see if they find another mutation, a resistant mutation of the EGFR. And that will tell them that they have to change the drug because it's no longer sensitive to the L858R or exon 19 deletion drug. And finally, my favorite part of this talk, I hope you enjoy this too, is how can a radiation oncologist be the one in charge? I will share a confession with you. The reason I am in radiation oncology is because of a man who was the Hefe in the multidisciplinary team. His name was Prabhakar Tripurnini. At the time, he was the chief of radiation oncology at the Scripps Cancer Center in San Diego. He was also the director of the cancer center itself. I was a medical student. I thought I wanted to be a surgeon, and I went to the tumor board, and this guy was a boss. Everyone listened to him. Why? Because he was prepared. He knew the information. He could answer the questions by diagnosis. A true MDT has diagnostics doctors, and he knew all of the treatments. He knew all the trials. He was the smartest man in the room, and everyone respected him. And I think anyone listening to this can do the same because we really are some of the best trained clinicians in all of medicine with our long residency. We talk to every single specialty. We know the language of pulmonologists, diagnostic and interventional radiology. We understand thoracic surgery principles. So there's no reason why we cannot be the Hefe in the room. And how do you be the leader in the room? I'll just share with you what I've learned over the last 20 years of my career. The first is recognize that the MDT is diagnostics and treatment. We must know everything about diagnostics. We must understand EBUS, what it can do, what it can't do. When should you do a percutaneous biopsy with CT? When should you do EBUS biopsy with bronchoscopy so that you can help direct the conversation and, of course, the patient care? And when someone isn't saying something, if you know it all, you can speak up and ask the question so at least it's all brought into the light. And, of course, treatment, we have to decide, help make sure everything is on the table. That way the team will look at you as fair and balanced and really a supervisor of what's happening. The second is you cannot do this if you do not know the language of the other specialties. Here at UCLA, when the residents do a rotation on the thoracic radiation oncology service, they are invited to go watch a bronchoscopy and talk to the pulmonologist for half a day. Same thing in pathology, same thing in radiology. They have to go to the operating room, watch a VATS or robotic lung resection and learn how they communicate with each other, talk to the patient, understand the experience. And then when you're in the MDT where everything is cold and sterile, you will have seen it all and you can add color to the conversation and you must speak up. In this world, nothing is ever given to us. We have to take it if we want it. Number 3, it is absolutely appropriate to be curious about surgery. Whenever we're looking at lung resection, and the patient's going to surgery, the question isn't whether to have surgery or not. I ask questions. Hey, can you tell me, which vessel do you clamp? Can you do a wedge? Would you do a wedge? Would you do a segment? Which segment will you take out? What about this? What about that? What about, there's a big emphysema. Could you take out the whole lobe with the patient breathe better? And then the whole MDT is watching you and they are learning that you are curious. More importantly, you know a little bit about everything. And so you should be the boss. And then next, teach everyone about radiation. Show them pictures with Zoom and Teams and things like this. It is the best time ever to show. And oh my gosh, they all say, wow, I never seen a radiation plan. That is amazing. And please do not use the word toxicity when you're talking about side effects. This is a very scary word. It has the connotations of like poison, pollution, waste. Okay. Just say adverse effects, side effects. This is much gentler. And it's basically, I think we kill ourselves by using this term toxicity. Next, we have to teach everyone how to monitor the scars after radiation. I have made it very clear to all of my colleagues and my patients. After this treatment, in about 3 to 6 months, there will be a scar there, and I will monitor the scar, and I need to look at it because I'm the one to tell you whether it's a radiation scar or not. Other things you can do is just teach people about when radiation can help. This is a very, I think, a landmark paper by Larry Marks now about 15 years ago, where they were getting all these calls from the emergency room late at night on the weekends, and they would go back and look at the scan and say, how come nobody called radiation? So here you can teach people, say, look, you've got a tumor about to collapse the right upper lobe airway, and maybe I should give some radiation before your drugs, or maybe the patient's getting drugs and this is growing. Instead of trying the next line therapy, let me give, 5 grade ×5 or something like this, so the patient keeps breathing and doesn't end up in a hospital, right? We want to keep them at home. So we can teach people about impending doom. Next, we should teach people exactly what stereotactic radiosurgery is. They don't know, right? We see the pictures all the time. They never see it. They probably don't even know where the radiation oncology department is. Show them the pictures. Teach them about spine radiation. We no longer treat through and through. Sometimes my colleagues in medical oncology say, oh, yeah, it's a spine map, but the patient doesn't have any symptoms. Well, they're going to have symptoms if it doesn't get controlled. So I show them the picture of SBRT so they realize it's very safe and easily tolerated. Next thing, we teach our poor, metastatic patients about palliation and teach, like, look, this is not going to cause any nausea or problems. It's just going to help them get off the morphine. And then teach them about electron therapy. They just don't know about it. If we don't teach them, they'll never learn. And then finally, this issue of radiation monitoring. This is a case that happened in my institution, and I actually presented it at our tumor board because there was a little bit of a mismanagement. So this is a patient of mine, T4N0, no nodal disease. We gave chemo RT just to be safe all the way through. It was too big for SBRT. And then 4 months later, no symptoms. They saw the scan. The scan report said pneumonitis. I don't know why. That's scar. It's not pneumonitis. The patient had no symptoms, no cough. Actually, was breathing better. And what did the team do? They stopped the durvalumab and started on prednisone. So here again, I'm a 0 CTV. This is the PTV margin that you're seeing. And what happened was they put the patient on steroids. And ultimately, when I found out, I told them, please, this is only radiation pneumonitis. It's not the durvalumab. They thought this was durvalumab pneumonitis. So we really need to be involved with monitoring the scans. And then my final message to you is, please, we have to minimize the public fear. There's so much fear about radiation. It's a very scary term. And I think we often do not hear ourselves talking. And I hope that you will read an editorial that is currently accepted and about to be published. I was very lucky to write this article called Missing the Target: Radiation Toxicity and Public Fear with the editor-in-chief of the Red Journal and the incoming president of Astro, who are just incredible writers. And what we do is we describe why it's so important to stop using the word toxicity, at least putting in the headlines, and use it maybe only for clinical trial reporting. And so that our colleagues and our patients aren't so scared about radiation therapy. So thank you so much for inviting me. This is a picture of my multidisciplinary team. I work with people in all different specialties. In the front, in the suit, is a cancer center director. On the left is a chief of cardiothoracic imaging. Behind her, the black fellow there is a football player whose wife died of lung cancer who works with us. And the woman with the glasses in the back, she is the PI of the National Lung Screening Trial. And the rest of the picture is clinical trialists, pulmonologists, radiologists, and the way, really the best way to give the right treatment is to have a good, strong team that works together, whoever it is who pulls the team together so that the patient doesn't just get one opinion after another. And that's the end of my presentation, Antonio. Thank you so much.
Well, thank you so much, Dr. Moganaki, for that enlightening and powerful presentation. We are now going to open the floor for questions from our audience. Please feel free to type your questions in the chat box. We'll do our best to select a broad range of topics. Les recuerdo que contamos con servicio de traducción simultánea, por lo que pueden hacer sus preguntas en el idioma en el que se sientan más cómodos. Les invito a aprovechar esta oportunidad para la interacción. We have some questions already posted. I'll start with a question to get us going. So, when should SBRT be considered a true curative option in early stage lung cancer in selected patients without biopsy confirmation? And how will you feel comfortable for follow-up?
I never do it without reviewing the images with radiologists and pulmonologists, and even sometimes, but not always, the surgeons. And if the radiologist said, this really looks like cancer, and they tell me, or the pulmonologist says it's unsafe to biopsy, I just think it's too high risk to watch. and I go forward. If it's a pure GGO, we can watch it, but if it's solid, we treat.
Great. So there's a question from Dr. Hector Aymerich. Could you share about your current or upcoming clinical trials, particularly in metastatic or ultracental tumors?
So the big trials for metastatic tumors is the CURB-2 trial in Canada, where they're going to be repeating that Memorial Sloan Kettering study where oligoprogression for non-small cells. So that's just enrolling. In the UK, there is the HALT trial, which is for EGFR positive to see if local therapy helps them. That is the only study I'm aware of phase 3 for EGFR positive stage 4 disease. For central disease, there was the Sunset trial that Dr. Palma and Dr. Giuliani had, I think, even published or at least presented recently. And there's equipoise problems. I don't think we want to push the boundaries much more. There are view rate-based studies that are trying to do the 5-fraction for ultracentral. Again, I just give 15 and, it's just two more weeks of treatment. And then we are waiting on a funding to do the 1 versus 5-fraction study in the VA. And if approved, that's a 550 patient phase 3 study to prove maybe once and for all that 1 is actually better than 5. We don't know. There's reason to believe if you wound the lung only once, that is less harm to the tissues than wounding it 5 times. And this whole thing about 30 is too much, and 10, none of the models work after 6 gray per day. So we have no idea how 10 gray works or 30 gray works based on a mathematical model. We need empiric data, and there are 2 phase 3 randomized trials that suggest the 1 fraction is gentler. I give 1 fraction all the time. That is my standard. The patients get about 20% fatigue for about several weeks, and then they bounce back. And then afterwards, but they never develop pulmonary symptoms. They just develop fatigue. It's very odd. I don't know what's going on.
Okay. From Dr. Salvador Gutierrez, about your post yesterday in social media, pulse electrical fields for lung cancer. What are your thoughts on this treatment option?
I think I'm going to sign up to do a trial. So again, the goal of the PEF is not to kill the cancer, but to release the neoantigens. And again, because I am very curious, I study what's going on in medical oncology. These PD-L1 tumors are a big, big problem. Nothing works. These are the patients who progress, develop brain mets, spine mets, liver mets, and then they stop coming to us, right? Then they die. So I think for that population where the drugs still aren't good enough, it's worth trying. Now, how do you get it there? In the study that I posted online, 90% of them were via bronchoscopy, only 10% via percutaneous, and the only pneumothorax they had was from the percutaneous. So we'll see, where it's available, and I think it's trying for stage 4, but the chances of the study being negative is high, but at least they're going to try it with a phase 3.
Great. So for Dr. Francisco Lozano, agreed on no CTV, but how are CT scan simulations done? 4D, breath hold, PET-CT scan fusion, how often is COMBIM CT done? Daily, weekly? And will you change CTV posture if none of these are available?
Yeah, so there's 2 questions here. How do you do the simulation, and then how do you do the image guided on the day of treatment? So for simulation, at UCLA, we use something called 5D CT. It's very important to know. We're trying very hard to commercialize it to get it out. But when you do 4D CT, you have the sine wave, and then ultimately you only capture 6 seconds of breathing. It could be the wrong 6 seconds. Your ITV could be wrong. The tumor could actually move more on the breath number 2, 3, and 4, but you only caught 1. 5D CT captures it all because it's 25 scans. The therapist just press the button and the patient slides in and out 25 times. It then uses registration and fuses it, and you get the true thing. So I always get a 5D CT. Let's just say it's 4D CT for your purposes. Next, I look at the movement. If the movement's too much, I go to gating. And I really think all centers, the lungs, the tumors move so much. You really should have gating. And with gating, what happens is, the patient breathes, or let's say the tumor comes down during the breath, and then they exhale, and then you treat. As soon as they breathe, you stop. And then you get what's called a gated window, and you just treat that. Whether you miss the tumor or not is nothing to do with the CTV. The CTV is all the principle about invisible hairs of disease, right? So the PTV is all you have to worry about. And then if you want high quality PTV decisions, talk to your top physicist. They will tell you when you're going to miss or not miss. So that's the simulation and the margins. On the day of treatment, absolutely cone beam CT every day. I can't imagine skipping a cone beam CT. And when I do it, the rule is I tell the therapist, turn off all the structures. Only one structure should be on, the IGTV. The smear of the tumor should align with the IGTV. Do not turn on the PTV and cheat. It should be a match-match. If it's not a match-match, you might want to resimulate and adapt the plan.
Okay. From Dr. Germán Chavez says, big fan here. Dr. Moganaki, based on your experience, how do patients perceive the differences between surgery and SBRT in terms of quality of life and treatment preference, and how might these perceptions influence clinical decision making?
Well, in our randomized trial, once they learn both are probably the same, we don't know what's better, this trial will help us answer, they really push for SBRT. Nobody wants to go to the operating room. I've met so many thoracic surgeons. I actually think I might know more thoracic surgeons than any radiation oncologist in the world. And I've talked to them and they say, Drew, this is my life. Every patient I have to consent for surgery doesn't want surgery. So as soon as they learn there's a non-surgical option, they're going to want it. Now, there's going to be some patients who are really scared and based on fear, they want the surgery. But if you have all these results and the pulmonologist and the family doctor say, look, SBRT is really good, it's going to be very hard to push people to surgery. And we have cases where like 60% of the lobe is full of tumor and the patient wants chemo RT. I say, look, you got to go to surgery. They're just going to get the whole thing out in one lobe. I'm going to cause a lot of pneumonitis. But that's for bigger tumors. For the smaller tumors, I tell you, like they just get fatigue. And if you have good IGRT, they're not going to develop pneumonitis.
Good, thank you. From Dr. Carolina Humada, do you think liquid biopsy will be a good option for initial follow-up in early-stage lung cancer patients that received SBRT without histologic confirmation?
So there's one Japanese study that showed if you got the liquid biopsy before the SBRT, it predicted whether or not the patient was going to develop metastasis. We're not worried about the target. 98% control. I think there's major problems with the literature. It's not 85, 90%. It's 97, 98% like the Japanese report. And so its question is, was the patient understaged? They have lymph node metastasis. Did they have a liver metastasis that was invisible? And liquid biopsy can help with monitoring that. What are you going to do? The test is positive. You're just going to create anxiety and panic. I think what it needs to do is use in the future to take those SBRT patients and give them some drugs because there's more invisible disease than you can see. But you have to do randomized trial to show that those drugs help them.
Just some few more. From Dr. Christian Orea, what lessons can we learn from your work at the VA regarding access to advanced treatments in resource-limited settings?
Yeah, so in our VA system, only half of them have SBRT, and it's not resources. The number one problem is the quality of medical physics. So I have been working with ALLATRA and now SOLAR, which is the presidents of all the Latin American radiation oncology societies, including yours, is working together on how to improve the quality of technology. And as you can imagine, Varian Siemens is interested, Elekta, MIM, now General Electric because they own MIM software. And we've been able to convince ourselves that if there's going to be one major mission, it is to improve the quality of medical physics education. Your medical physicist should never be a second-class citizen. Without the medical physicist, you cannot deliver high-quality radiation. This is our problem. The RVA medical centers that don't have SBRT, the radiation oncologist is coming out of outstanding institution, Harvard, WashU, whatever, right? The physicist says, no, I don't know how to do it. I don't want to do it. And if the physicist doesn't approve it, you can't deliver it. So that's what I would say, resource limited or not. I mean, look at the nation of Chile. I mean, unbelievable. SBRT, IMRT almost everywhere. And it comes down to the strength of the physicists who often trained elsewhere. And so my hope is in the next 5 years, and I think urgency is important, let's fix the medical physics program. If there's centers that don't have high quality program, the different countries should work together to fly the physicists to the right center and come back, and you can do anything. I worked at a VA. When I showed up, there was half IMRT and there was no SBRT. Within 6 months, it was all installed. Why? Because we got rid of the physicists, we got a strong one, and it was just irradiating phantoms, commissioning the machine, because these machines can all do it. It's the physicist knowledge that's required.
Thank you. Dr. Silvia says, in 3 keywords, what do you think every radiation oncologist should have in mind to be leading at MCC?
Prepared, confidence, and be a good teacher.
Great. From Dr. Eric Salvador Hernandez, in ultracentral lesions, knowing that planning is performed with 4D-CT, how do you select patients in whom you use breath hold as a complementary technique?
I think you should always minimize the excursion. So any motion mitigation like breath hold, if you have it, of course, use it. And then I say, when you go to 15 fractions, you just don't worry anymore about, the movement and OAR and all those things. It's all okay. And of course, another thing I didn't mention, when I do IMRT planning, I use the same SBRT tables for D2CM and R50, right? It's all about compactness and let the dose get hot in the middle. But for ultracentral, you got to be careful. You got to make sure that the bronchus doesn't slide in and out of that hot spot. We think that's what happened in Hylas. So you had a bronchus, you had 150% hot spot, and while the patient was breathing, it came in and out. And it injures the blood vessel and the cartilage of the trachea or bronchus, and that's where it was bleeding. So keep things cool when you're close to the bronchus.
From Dr. David Hernandez, thank you for your time and for sharing your expertise. I'm a big fan of your content on social media. At your institution, how do you approach PCI for limited stage small cell lung cancer in the MRI era? And do you offer PCI to all eligible responders, or do you select some patients for close MRI surveillance instead? He says he's aware of the Takahashi trial, addressed this setting in extensive stage patients and show no overall survival difference with MRI follow-up. Does that influence your practice in limited stage cases? And finally, when you use PCI, do you routinely employ hippocampal avoidance?
Do you know this game in your country called Ouija? Do you know it?
We do.
I have this board in my office, and I use it as a teaching example where you dim the lights with the candles, you put your hand on this thing, and you see if it goes to yes or to no, because that's where we are. We don't know. But so I say that to say I do selection because I think I'm smart enough, but I could be wrong. The criteria that I use and my colleagues use is if the patient's super compliant, let's say they come with their wife, they're never late to the appointment. MRI every 3 months, especially if it's low volume disease. Every 3 months, MRI because they're not going to miss it. If the patient's a little bit confused, drinking, still like partying, or maybe I got like an executive in LA, right? And he's traveling. Oh, I'm doing business in Hong Kong. I'll be gone for 6 months. Treat the brain. He's going to miss his appointment. And I've run into trouble where for example, I had one patient, she was having some sort of weird things and she ended up in a rehab hospital and we were doing MRI surveillance and then she died of brain mets. Her chest was under control. I'll never forget this case. I didn't stop to think. I have to be very careful. So I think the standard of care is PCI unless you can double trust that they will get those MRI scans every 3 months. If they get those MRI scans every 3 months, then you can reproduce the results of the Japanese trial.
From Dr. Carlos Sebastián Wilbert Gamboa, I'm very grateful to have had the opportunity to listen to a true master in radiation oncology and clinical research. From Dr. Julia Sainz, in locally advanced stages, would you recommend de-escalation to mediastinum and nodal areas for better immunotherapy response?
Not yet. If you want to do something creative, the thing you might want to do is sequence. I am working with pharmaceutical companies to see if I can get some sponsorship. We have a randomized trial we're designing in the VA where we give, chemo immuno, and then we just do 3 weeks of RT alone. I think if you want to de-escalate, and that doesn't help with the lymph nodes. I don't know. I think if the tumor regrows in the lymph nodes, it's very hard to defend yourself. We're not there yet. We have to know how to select the situation. So if anything that we think is FDG positive, biopsy positive in the mediastinum, you gotta treat it with full dose.
Well, Dr. Moganaki, thank you once again for your time, your insights, and for generously sharing your expertise with our community. Your presence here truly elevates this space, and I know many of us walk away tonight inspired and better informed. To our attendees, thank you for being here and for your thoughtful questions. If you'd like to revisit this session, it will soon be available through SOMERA's official platform. Please follow us on social media and stay tuned for our upcoming webinars. Until next time, take care and have a wonderful evening. Thank you again, Dr. Moganaki. Always a pleasure.
Same for me. Thank you so much for the opportunity.
Take care.